Good evening, respected professor, my dear students. I welcome you all to another session of PAISA DNB online academic activities today. First, I invite Dr. Muthupriya to present a case of 50 years old female of height 5 feet and 1 inch, weight 145 kg, posted for robotic partial nephrectomy. We will be discussing the anesthetic management. Over to Professor and Dr. Muthupriya.
Good evening, sir. Good evening, everyone. Today, I'm going to discuss a case about a morbidly obese patient posted for robotic partial nephrectomy. So, the given patient is a 50-year-old female with a height of about 5 feet and 1 inch and a weight about 145 kg, posted for robotic partial nephrectomy. So, I'll ask the detailed history regarding the patient and ask her about the presenting complaints. Then I will come to what is the cause for her weight gain, obesity, whether it is due to a metabolic cause or drug related cause like due to steroidal intake or due to environmental cause or genetic cause, and whether she is on any treatment for that, any diet supply, diet modification or weight reduction program she is on that. I'll ask, and I'll look for the associated co-morbs like type 2 diabetes mellitus, systemic hypertension, CAD, OSA. I'll ask the OSA history like snoring, any history of snoring, any excessive daytime tiredness, sleepiness, obstructed sleep pattern is noted, and whether there is a, I'll ask about the Staubank questionnaire and when any history of hypothyroidism, Cushing disease is there. And then I will ask about the systemic involvement of obesity, whether there is any GRD risk, gallstones, osteoarthritis, and cirrhosis of liver. Then I will come into the surgical history. Any past surgery is being done, and she's on any regular medications. Then general examination. I'll ask mainly regarding the kidneys function status, about whether what's the reason for the partial nephrectomy, like what is the exact problem. Then general examination, I'll come into look into the general status about her BMI. Her height is about 5 feet 1 inch. It is about 154 centimeter and weight about 145 kg. So her BMI comes about 60.35. It comes under super obese of about class 3 obese. More than 40 BMI comes under class 3 obese. And then I'll look into her IV status, her vitals, neck circumference, dentition, detailed RV examination regarding her mouth opening, malumpati grading, neck movement, any and neck circumference, whether there is any short neck, and waist circumference should also be noted. Then coming to the systemic examination, detailed systemic examination should be noted. Any and functional status of the patient should be noted. Any history of immobilization, any past history of DVT, bed sores should be also be noted. Coming to the pre-op investigation, routine pre-op investigations like CBC, RFT, LFT, blood glucose, thyroid function tests should be done. If there is a known respiratory comorbs, ABG should also be done in a room air, and pulmonary function tests can be done. Mostly the obese patient will have a restrictive pattern. If ECG echo should be noted, to look at the cardiac status of the patient, and chest X-ray should be done. If the patient is having a poor meds or restricted physical activity, pharmacological testing like dopamine stress echo should be done. If it is positive, then further invasive testing should be done. If it is an elective surgery, I'll ask for a weight reduction and diet modification. After that, it can proceed. If it is an emergency, we should proceed. We should undergo pre-op risk stratification and optimization. We should advise them for incentive spiro, nutritional supplementation. Coming to pre-op instructions, I'll ask her about her, ask for 10 hours of fasting and ask to avoid, I will avoid pre-medications as obese individuals are more sensitive to sedatives and analgesics. Ask for anti-aspiration prophylaxis with H2 blockers, proton pump inhibitors, or sodium citrate. If the patient is a known OSA and he's on BiPAP, I'll ask them to bring it to the hospital and advise them to use it on the night before surgery. DVT prophylaxis should be mainly started before surgery with the subcutaneous heparin or injection enoxaparin. If he is on like known medications like anticoagulants or antiplatelets, I'll ask them to stop 5 days before surgery and withhold OHAs, insulins, or AC inhibitors, ARVs, if any he's taking any, I'll ask them to withhold on the day of surgery. And antibiotic prophylaxis should also be given. After so the main concerns regarding this patient, she's a class 3 obese individual. So we will be having a difficult airway, IV access. That will be a difficulty in positioning and shifting the patients. And associated comorbs should also be, it's a concern. Robotic concern like pneumoperitoneum concern will also come under this. And partial nephrectomy being a major surgery, there is an increased risk of intraoperative events also, like increased bleeding can happen. So we should look into this and further manage it. So coming to the intraoperative management, if the patient is the known difficult airway, I will proceed with awake fiber optic intubation. If we can manage, it can none under normal induction with special consideration. We should safely transfer the patient to the special OT table designed for that appropriate weight. Trained staff should be kept ready. Difficult airway card should be kept ready. Routine monitoring should be done. If a large BP cuff should be available. If the patient is having a difficult IV access, ultrasound guided IV line or central line can be placed. And if there is an associated cardiac problem, then we can place an artery line for BP monitoring or a routine ABG sampling. After monitoring, we can come to positioning. The patient should be held up in a upright position, like ramp position or head up position. After that, we should safely secure the patient with strapping or side support. Adequate padding should be done. The induction should be adequate. In induction, that should be adequate pre-oxygenation, as they are more prone for desaturation. For about 3 minutes, that should be adequate pre-oxygenation. After adequate pre-oxygenation, we should attempt to intubate. Apneic oxygenation can also be done during laryngoscopy. We should use short-acting drugs and short-acting drugs. RSA can be tried if there is a risk of regurgitations, and rice tube can be placed. After induction, the patient should be safely secured and properly positioned. A partial robotic nephrectomy mostly done in the lateral position. So the patient should be turned to lateral position based on the side, and adequately side supports should be given and strapped well. Since it's being done in a robotic manner, robotic consideration should be done. So as the patient needs prolonged immobilization, transfusions like infusion pumps should be kept ready, and long IV sets should be kept ready. Then the patient is maintained under air, oxygen, and sevofluorine. Short-acting opioids like fentanyl infusion can be given, and atrac infusion can be given. Then the patient is put in pressure control ventilation to maintain the peak cardiac pressure, as due to robotic pneumoperitoneum concern, and the obese patient will have a high peak cardiac pressure. Fluid management should be based on the goal-directed fluid therapy based on the ideal body weight. Urine output should be monitored. Fluid warmer should be kept ready. During the intraoperative, we should look at intraoperative surgical events. We should look into the bleeding, as they are more prone. Partial nephrectomy is more prone for bleeding. So appropriate blood products should be kept ready. And if the surgery is getting prolonged, then the patient can be extubated the next day due to edema or due to prolonged infusion. The drugs get stored in the fat molecule, so next day can be extubated. If it is a short duration and patient is hemodynamically stable, then the patient can be extubated when he is fully awake with spontaneous support in head-up position. Ensure the difficult airway cart is ready, and that should be complete reversal of neuromuscular blocking. We can put neuromuscular blocking if the TOF ratio is more than 0.9. We can extubate the patient. Post extubation, we can keep the patient in NIV or CPAP, and that should be continuous O2 like O2 supplement and continuous monitoring of the patient for saturation. After that, we can advise for DVT prophylaxis, early mobilization. A partial nephrectomy being done in a robotic, the pain may be minimal, but that maybe we can give a epidural like a blocks like a quadratus lumborum block or a erectospinal block can be given, or a short acting short NSAIDs paracetamols can be given. If we need opiates can be given. If there is a large tumor and if they are planning for if they plan for open, if we can give epidural preoperatively itself. And in the post-operative, we should look at the drain output to look at bleeding in case of any bleeding. That's all, sir.
Have you seen a case of robotic nephrectomy which is done in your hospital?
Yes, sir.
Very good.
Yes, sir.
So I can assume that you have seen a case of robotic nephrectomy being done.
Yes, sir.
Isn't it? Have you
Yes.
attended a case like that?
Yes, sir.
Right. So you are able to incorporate all the points required for the answer in your presentation. But it needs to be put up in a more polished way.
Okay, sir.
Okay? You have mentioned almost all the points required in the exam to be answered, but you can organize it in a better way to give a more appealing presentation. That's what I feel.
Okay.
So here we have, first thing you have to say here is always I have told you, whenever a case scenario is given, you will have to first address the challenges that you are going to face in this case.
Yes.
Okay? So what are the challenges you are facing in this case?
Like morbidly, like super obese patients.
This is a morbidly obese, class 3 obese patient.
Yes, sir.
Fortunately, such patients don't come to us because in our population, unlike your Western people, we don't get that much of super obese patients here.
Yes.
Okay? So we are lucky. But if you finish your course and then you go abroad and practice there, you may encounter such 60 BMI patients, which is quite rare in our setup. At the most, we can get 30 or 35 max. Right? So class 3 obesity itself is a big problem. That's the biggest challenge, first thing we have to. Second thing, the surgery is planned in the robotic technique, robotic assisted nephrectomy. So the challenges of robotic assisted nephrectomy is also there. So you can classify the challenges that you are facing into these two groups. One is the management of a morbidly obese patient with the attendant risks of all the obesity. The second is the challenges in the robotic anesthesia. And the first and foremost thing that you have to say in robotic technique is your access to the patient. Is it easy in robotic technique?
No, sir.
That has not been mentioned in your answer at all.
Yes, sir.
Okay? So
Limited
you just said patient will be operated in the lateral position. Once the docking is done, you have no reach to the patient, isn't it?
Yes.
And the problems of tube migration, basal atelectasis and intraoperative desaturation or intraoperative sudden bleeding, surgeon deciding to abandon robotic and trying to convert to open procedure. Of course, you mentioned about that. And so all these complications are there. And so you have to classify them into these two categories.
Yes, sir.
And as I showed in my last class, whatever case discussion, we have to organize our pattern of answering from history taking, then examination findings in the patient, relevant investigations needed, then risk stratification, then go for optimization, preoperative instructions, then plan for intraoperative management, post-op management, pain relief. That is how you must organize your answer in all the. So you can do the subheadings like this and then present it more clearly to the examiner under these headings, which will give a better impression rather than jumbling from investigation to suddenly asking for history, and then from history going in for some examination finding like airway.
Yes, sir.
All that jumbling should not happen. Okay,
Okay,
so it should go in a smooth way to present all these things in the orderly fashion so that you will also not forget any points which you
Yes.
have to mention in the exam. Because here you are reading it from what you have prepared, but
Yes.
in the exam you are going to say it from your memory. So in that situation, unless you train yourself to present in an organized way, you will forget a few points. And the examiner will pick out only that and say, oh, you have not told in this particular case, this is the most important point, and they will catch you on that. Okay, so it's always better to train yourself to go in an orderly fashion. So otherwise, you have beautifully narrated all the points. Only thing it needs to be little streamlined and present there.
Yes, sir.
So without wasting much time, sorry.